It's the month of October. It's usually the Breast Cancer Awareness Month. And as we come to the final Friday of October, let's have this conversation on breast cancer awareness and the load in the country, the disease load in the country, and how we're dealing with it. We're joined by two people in the studio. Dr. Dulcie Wanda is a Senior House Officer, Radiation Oncology Registrar at the Kenyatta National Hospital. And Dr. Hussein Dimbil is General Medical Practitioner at Zazi Hospital. Good morning.
Good morning.
Welcome to Kenya's Biggest Conversation.
Thank you. Good morning.
Karibuni sana.
Asante.
Now we're going to have a conversation about, this is usually a conversation that many people think that they understand, but then we realize that there's a lot we do not understand, especially when it comes to diagnosis, management, treatment of cancers and breast cancer. But to welcome you to the conversation, let's start with the day's proverb. CT has been giving us proverbs from Zanzibar the whole of this week.
Yes. And
the proverbs, of course, come in Kiswahili. So assignment number 1, listen to the proverb. Assignment number 1A, translate proverb into English. Assignment number 1B, interpret the proverb. CT? No, we are starting, the final KCP is happening next week. So this is it. KCP has multiple choice, but this one, 0 multiple choice. Yeah.
Makali ya jicho yashinda wembe.
Makali ya jicho yashinda wembe. Dr. Wanda, into English.
I think it means that the eye is more powerful. What it can see and what it can interpret is very, very deep. And it has to do with also the saying, macho hayana pazia, I think. Sina uhakika lakini. I'm not sure what that means. But I think the eye is very keen. It can peer through sharper than something that has a sharp edge.
Okay. That is 1B. Where is 1A? Direct translation.
Direct translation.
For those that don't understand Kiswahili.
Makali ya jicho ati makali ya macho. Makali ya jicho yashinda wembe.
The sharpness of the eye is sharper than a razor, perhaps.
Dr. Dimbil.
I was thinking the same, like the sharpness of the eye is sharper than a blade. And that it might point out to our eyes can pierce through our souls, maybe sometimes sharper than a razor can.
Have you ever heard of this, people saying, ameniangalia na macho mbaya?
Yeah, I've heard of that.
Precisely. No, does it mean that the eyes were bad? What does it mean?
It's the look. It's the look.
And what does the look portend?
The feelings of the person.
Exactly. And sometimes that look can be a much firmer message than any words can utter.
Interesting.
Makali ya macho hayana pazia.
Ati makali ya macho hayana pazia.
All right. Karibuni sana, Daktari.
Thank you.
Let's start with defining breast cancer.
Okay.
Who do you want to start? Let's start with you, Dr. Dimbil.
Okay. Breast cancer can't be specified as one specific disease. It is a conglomerate of conditions, but basically it is abnormal cells that grow out of control within breast tissues, and if not found or detected early, can spread to other organs via lymph nodes and lymph vessels or blood vessels.
Okay.
Does that sound complex?
Not really.
Okay.
It's just unwanted things happening.
Yeah. So pretty much every time you're alive, there are cells that are dividing, including breast cells. So what happens is one cell that stops having the normal division. A normal cell should grow, divide, and die off. So you have a problem in the genetic makeup of that cell such that it divides uncontrollably. It doesn't die when it should. It has the ability to break off, go into the blood system and go to another organ. So that's one of the signs of a cancerous tissue, that it's able to invade. It's able to leave the bounds of where it should be, invade, break off, and even go colonize a different organ. So that's what breast cancer is. So it's that one cell that is irregularly dividing within the breast that now makes a group of cells that are abnormal.
So you're saying it is a cancer.
Yes.
It just so happens this one
Starts in the breast.
it starts in the breast.
Yes.
Is there something peculiar about the breast that it would make this form in this manner? Because, yes, we have cancers of other areas in the body, but this one in the breast, is there something about it that would then say, it would create a condition through which now this cell would behave abnormally?
Yes, there is. So the breast is very sensitive to hormones. If you look at development and during puberty, exposure to estrogen makes the breast grow. As women, we have the monthly cycle where estrogen levels go up and down depending on the time of the cycle. And that is a good environment for those cells because they respond to hormones. And you'll find majority of the cancers that develop are hormone receptor positive. And that points to the risk factors of breast cancer, that if you're having a long period of exposure to estrogen, for example, you have your child after the age of 30, you do not breastfeed, because when you breastfeed, then you almost have 3 months of not having estrogen levels being high in the body. If you do not have children altogether, that's a risk factor. And all these risk factors I've mentioned initially are pointing to estrogen, the hormone. So the breast is special because it responds to estrogen hormone, a hormone that we have as women. However, breast cancer is not just in women. We have a percentage that is found in men. It's a lower percentage, but remember, since they lack breast tissue, then it means it's more aggressive.
Yes.
For a lady, there is space for the tumor to grow and thrive within the breast. But for men, their breast tissue is very minimal, meaning it is easy for it to go to the bone and eventually into the lung. And since most of the cancers present a painless lump, it means presentation almost happens late, both for women and men.
Okay.
What makes it move from the breast?
Maybe you can take that, Dr.
Okay, what makes it move from the breast is initially there are different stages of cancer. It starts from stage 0 to stage 4. Now, initially, stage 0, it is within its own walls or the cell walls of the original cell that it comes from the breast tissue. Now, as it moves forward, as the cancer grows, it grows out of the endothelium or the cell that it originates from. Now, as it goes on to stage 2 and stage 3, it reaches a point where it connects or it gets in touch with the vessels that we were talking about recently, like the blood vessels or lymph vessels, which carry a fluid called lymph. Now, when that happens, it spreads via those vessels to different organs, and that is the initial way that it spreads to various different organs.
Are there parts of the body where this cell could go and not find conducive?
Not really.
Not really. Actually,
Good.
cancer, metastasis, so when you're talking about a piece of cancer that has broken off from the original tissue, when it moves, we call that metastasis. So the only parts of the body that metastasis wouldn't happen are the parts of the body that are dead. And that we're talking about hair, we're talking about the outer part of the teeth and maybe nails. But as long as there's blood vessels, remember, a piece of the cancer is breaking off and going into circulation. So it will be pumped with the heart. So wherever that can go, it is possible to have the tumor breaking and going. However, we do know there are certain areas it's more common to go.
Okay.
For example, the lungs, the liver, the brain, and bone. And that really guides how we do the staging test. Once one has been diagnosed with cancer, then we would really want to know a CT scan of the chest. That's imaging of the chest to know has it gone to lung, because we know it's possible. Then we'll do a scan for the abdomen to know has it gone to liver. And that kind of guides us to stage the patient. As Dr. had mentioned, staging is important for us to know how are we managing the patient.
Okay.
I have 2 questions, but the first one then. So does the peculiar that word
Yes.
of this particular cancer then lend to it being the most let's go look at breast cancer as the number 1
Yes.
cancer. Does that lend to it being now the most widespread cancer because of its peculiar nature? Is that why we're saying that it is the one that is that we see most of?
So I think we go back to the fact that we have estrogen in the body.
Okay.
And that's a normal hormone a woman has. So that puts it at risk. There are other risks forever. Maybe, for example, having radiation as a child, maybe for a tumor during childhood. We're talking about obesity as a risk factor. We're talking about alcohol and cigarette smoking as risk factors. So when you look at this, there's some that are lifestyle, there's some that are modifiable risk factors. We can do something about it, like not being obese, working out, ensuring we are taking balanced diet, food that's not rich in very unsaturated fats. We are also reducing our cigarette smoking, stopping, actually, that is what is recommended, and alcohol, really putting it at an all-time low, or perhaps, if possible, totally stopping to reduce the risk. And then there are those that are genetic. For example, if we have BRCA1 or BRCA2 gene, like we know Angelina Jolie, she had the BRCA gene, and that made her know she's at a high risk of getting cancer, and that helped her have surgery before she had her boobs and the womb removed, and that reduces her risk, because we know the genetic aspect of it makes her risks very high, almost like what people now in Kenya would say sure bet, like it's gonna come because you have the risk factor. So I guess the fact that they're genetics, the fact that there is the hormonal, the fact that there are things that are modifiable that we are not doing would help us understand why is cancer on the all-time high. The other thing is, despite the fact that cancer is on all-time high, we can screen and get the lesion before it even shows as a lump. And that's what we're really encouraging people to do, to get it before it's a lump, because that really helps how we can treat the patients and the outcomes that they can have.
Okay. So if we talk about you finding cancer in the breast, and then it can spread to other places. It can spread to the lymph nodes. It can spread to the lungs. Is it still breast cancer?
Yes.
So it leaves breast, and so it remains in the breast for sure, but then it goes to the lungs. Is it still classified as breast cancer even though it's present in the lungs, for example?
Yes, it is classified as breast cancer. It is just a metastasis.
Okay.
It is part of that cancerous cell that has spread to another organ, but it's still, even if you take a biopsy of those cells, it's still the same cells as the ones that originated from the breast.
Okay. So for the longest time, we say that the stages we talk about 0 to 4, and for the longest time we've been told over and over again, screen regularly, do this, do that, because if you then are able to catch cancer in the preliminary stages, the possibility of you then healing completely from it then are very high, or then the interventions that would then be required can then come in early. What is it that would be done at this level 0, 1, 2 to stop this spread that would not be done if you find it at 3 or 4?
All right. So cancer can be managed in a variety of ways. We can have surgery, broadly. We can have chemotherapy. We can have radiotherapy, and we can even have targeted therapy. So for most cancers, if you're able to remove the tumor totally, then you reduce the chances of the tumor coming back. You reduce the chances of it metastasizing. So that's the advantage when we catch it like at stage 0, where it has not crossed the basement membrane. So it is very at a level that once you excise the tumor, you remove it, then you've removed the whole tumor. Then you'll have a chance to look at it under the microscope and see, is it fueled by estrogen? And if you find it's fueled by estrogen, then the plan is to give something to block estrogen. So there's a tablet you can give if someone is premenopausal called tamoxifen. If they're postmenopausal, you can give a tablet called letrozole or anastrozole, and that blocks the estrogen. So in short, what you're doing is like you've cut off the gas supply. So even if it's a vehicle and you cut off the gas supply, it's not going to move.
Moving.
So the advantage is that you will have fewer treatment mechanism if the tumor is early. You can have surgery, you can then have radiation, and maybe the tablet. If this cancer has progressed, like it's big, it's maybe a T3 tumor, a large tumor more than 5 centimeters. We're talking about stage 3. There is heavy nodal involvement. The nodes in the axilla are involved by the disease. Then that means you have to start with chemotherapy first to shrink the tumor. Then you'll have to have surgery thereafter. Then chances are you'll have to have radiation, and possibly if it's hormone receptor, then you will have the tablet, meaning you will use more modalities of treatment for more advanced disease, meaning the side effects that you would get if you had only maybe 2 modalities compared to 4 modalities, you'd have more side effects. So the earlier we catch it, the less the treatment modalities we use, the higher the chances of you even having what we call breast conserving surgery. Remember, for women, breasts are more than just looking good. They represent who we are. And I always compare breasts to how men feel about their penis. So if we cut away the penis for the men, then I'm sure they'll be very uncomfortable. Pretty much that's what breasts represent. They represent who we are. It's the first thing when you look at a woman, you see it's the chest. And
No, you see the face. Sure.
many men would refuse. Daktari, what do you think? What do men see first?
Breasts.
They see the breast first. Let's be honest. So when
It's okay.
it's okay. We know the secret's out. The secret's out. So we know where. So that really affects a woman's self-esteem if one breast has been removed. So the earlier we catch breast cancer, then it means we can have breast conserving surgery, because the tumor is small, will remove enough tissue around it and still be able to reconstruct the breast, such that even if you looked at a woman, if she went swimming, if she wanted to wear a bikini, then it becomes much easier because her breasts are intact.
Okay. What are we looking at in terms of disease burden for Kenya, considering breast cancer today? A lot of women, if we look at when we started seeing the early diagnoses of breast cancer in Kenya and this region of the world, and then also looking at the western part of the continent, that a lot of medical practitioners, we didn't know what we were dealing with. Of course, times have changed now, where the science and the technology is much, much further along, and we can see. But now looking at disease burden for Kenya, what are we looking at now in terms of affected versus population?
I feel there is still a huge disease burden, because even though we are getting much better treatment modalities, we are still getting very improved mechanisms of surgeries. There is still a sense of ignorance, especially when we go to the less fortunate parts of society. And the WHO had stated that 1 in every 8 women are at risk of getting breast cancer. And that was a recent study that was done. And that being said, for example, I was seeing in one of our groups, there's a mama who's in Migori, and she had breast cancer. It had advanced, and she hadn't gone to hospital simply because she believed that with God's good grace from prayers and waganga, or these doctors were mtaa. She had her breast cancer advanced to stage 4, where when she came to the facility, there was very little that could be done. So the disease burden is still there. I feel for us people who are in metropolitan areas, we are more educated, but doing things like these where we need to reach out and spread the awareness to other parts of the country, I feel is very important, as opposed to the education that we are getting as us people who are more in the metropolitan regions.
Just to dampen the mood, 7 women die every day from breast cancer.
In Kenya alone.
Yes.
Okay.
Say that again.
7 women die every day from breast cancer. So, and sadly, they present late. By late, I mean when it's stage 3 and 4. So if you're losing 7 women, then that is quite a stark number.
Okay, Dr. Are these women who've already been diagnosed, they're under treatment, or is this a blanket figure that we're saying that even posthumously a test was done and you can find that this woman had breast cancer?
Yes.
Or are we saying these are women who are in treatment, who've been diagnosed, and they then pass as a result of the disease? What are we saying?
If we said that they're diagnosed, then people would feel being diagnosed is a risk factor to dying. So looking at the statistics and how the levels are increasing, then that's a statistics that is general to the population. Remember, when you're doing statistics to find out the incidence and also the mortality, then you're looking at a figure based on the population. So even if you look at the government documents by the National Cancer Program, that's a figure that has been put there. That is to help us see it is quite a large number.
It's huge.
It's huge. But what is the problem? It's because breast cancer and most cancers initially are not painful. So it's that lump you feel in your breast that's not painful. See, majority of the patients, I keep saying this anytime I get an opportunity, is we treat hospitals and doctors the way we treat police officers.
Yep.
When was the last time you went to the police station to say hi? Or I'm just here to find out, could there be a problem? Could we check on something? Is my car okay? We don't do that. So people come to hospital when they have pain. Because if it's painless, you're able to go to work. You're able to do your life.
Even with pain, people still continue.
Yeah,
and say,
depending on the
it'll go off.
threshold
Right.
of pain.
Yeah.
So we're talking about women and men being what we call breast aware. Know your breasts. Feel your breasts. Get a medical practitioner to feel your breasts. If you're above 40, get a mammogram done. Like, what's the excuse? In October, everybody's talking about breast cancer. We even wear the pink lapel just to remind everybody to get your breast screened. And that really helps. If you're below 30, then get an ultrasound done so that we can catch these lesions before you can feel them.
Okay.
Let's take a break. 29 minutes to 8. We are having a breast cancer conversation today, Health Friday, joined by Dr. Dulcie Wanda from the Kenyatta National Hospital. She is a radiation oncologist, and Dr. Hussein Dimbil, general medical practitioner at Equity Afya Kangemi. Keep it here for more. We're coming back shortly with this particular conversation. If you've got questions, you can post them on our social media handles, SpiceFMKE on Facebook, on Twitter, on YouTube. We'll ask them.
Spice.
October is Breast Cancer Awareness Month, and in the Situation Room this morning on this Health Friday, we are having a breast cancer awareness conversation, joined by Dr. Dulcie Wanda from KNH. She's a radiation oncologist, and Dr. Hussein Dimbil, general medical practitioner from Afya, Equity Afya in Kangemi. You said how many people die every day?
7 women.
7 women.
Yes, die.
Every day.
Every day. From
How
breast
many
cancer.
are diagnosed every day?
I haven't seen that statistic that really talks about how many women per day, but we know in Kenya then we have about 16.1% of the population that has breast cancer. That still tells us it's a large population.
Yes, it
and sadly, when we go to work as oncologists, then what we see is devastating. What we see is traumatizing. What we see is difficult to handle because sadly, many patients stay with the lesions for very long, for very, very long. So when you come when the disease is quite advanced, it reduces what we're able to do. It reduces the chances of you getting cure because you find the lesion most probably has gone to another organ. So I guess it's important for the messaging to go out there. Feel your breast. If you have a lump, let it get examined. The earlier we get it, the better. And that really helps to make sure we stop seeing these very large lesions, these wounds in the breast, or these heavy burden of disease.
Do men also get breast cancer?
Yes, men do get breast cancer. 1% of all cases of breast cancer is found in men. WHO stated that 1 in 836 men will develop breast cancer once in their lifetime.
Okay.
But just as Dr. had mentioned, the risk factors vary, just like for our ladies, and it varies based on age. It varies based on hormone exposure. So men who might be going through changes of gender, for example, might have that. And men who might have conditions such as Klinefelter syndrome. Have you ever heard of Klinefelter syndrome?
Sorry.
It's called Klinefelter syndrome. It's when a man is born with an extra X chromosome.
I see.
So it's an XXY chromosome. As men, we're born with XY.
Yeah.
As women, you're born with XX. But there can be a genetic mutation and a child is born with an XXY.
I should have paid more attention in my birth.
Yeah, so it varies, but it is, as Dr. Ali mentioned, very aggressive in men. So it is very hard to manage.
Something that always comes up in discussion. When we talk of this proliferation of cancer, we're talking about breast cancer. So let's focus on breast cancer. Is it that it's on the increase? Is it that we're able to diagnose better? Is it that we're more? What is it? And if indeed the proliferation is something that has happened, whether it is climate change related, whether it is dietary, whatever it is, what is it? What exactly are we seeing with regards to what we are now calling a proliferation of breast cancer?
So I guess it's multifactorial. I would say it's multifactorial in the sense that, one, as we move from being least developed to less developed to middle income, then we're having a more sedentary lifestyle. The more sedentary our lifestyle is, it means even for men, they have obesity. When men are obese, then they have higher levels of estrogen produced from the fatty tissues, and that is a risk factor to getting breast cancer. So there is the lifestyle changes that we're seeing. We are also seeing improvements in diagnostics. Previously, all the CT scans and the machines that would help and the mammograms were in Nairobi and in Kenyatta National Hospital. But through the efforts done by the government, then these machines have been taken to the counties as part of the decentralization. And that has helped improve diagnostics on the ground. Previously, we only had a handful of oncologists. Now we have a training program in Kenya to train oncologists. Previously, they all had to go to maybe South Africa or Tanzania or the West. But now we have a local program at the University of Nairobi. That means greater access to our doctors to specialize in oncology. And that means then there is what to do with the patient. Previously, maybe you're in Lokitang and you find breast cancer. Then what do you do? Then pretty much it doesn't even make sense to do a biopsy. It didn't make sense to even find out whether they have cancer, because what will you do? They'll not come to Nairobi. Their poverty levels are quite high. But now that we have oncologists decentralized, that helps. So there is what we can do. So that is motivating even doctors to do more screening, motivating people to actually know. And then there is awareness campaigns that, like today you've had in the morning. This gives people an opportunity to hear about breast cancer, to think, does the lump I have, should I go to hospital? Is it important? And maybe we really hope that this messaging will encourage someone to actually go to hospital and get screened.
Because look, you've shown us some pictures this morning, obviously, and we've seen some of these. And obviously you're having conversations with patients, and you're aghast sometimes when you think, what would make somebody sit at home with this level of disease? So when you have conversations, because I know reasons that we've heard as to why people do, but for a medical practitioner, what are they saying as to the reasons why they don't come to hospital earlier?
Well, some mentioned that they were busy. They had a child in class 8. They said, I'll focus on it later. Remember, it's not painful. So it will not stop you from going about your business. It's not going to give you a fever. You're not going to vomit. You're just going to have a lump that you feel maybe when you shower or when you focus on your breast. Pretty much the rest of your time, you're fine. So that makes people not really think of coming to hospital. They can always do other things first and push that away. Secondly, it's the denial. Because sometimes it's even us health workers. You have a lump. There are times you think and you wonder, could it be cancer? And then you tell yourself it is not. And I do not have a lump. And you move on with life. So that denial, I think it comes from the fact that we are not having many survivors being given an opportunity to share the story. It's where we began with HIV. Remember, the messaging we had was a very skinny man with a metallic plate. And that was the messaging we had. And it was HIV kills, AIDS kills. And that was to instill fear. But later we realized it was counterproductive. When people would fear the disease, they would not even come for screening. And the messaging changed. And the people who now were the advocates, the assumptors of those days, were people who were fine, people who were working. And then people could relate a bit more with HIV and take the steps to get treated because they had examples of people who are doing well. So I feel if we have more advocates and more people speaking about their journey, then people can look. So even if I have cancer and this lump that I have is cancer, then maybe I'll be okay. And that can motivate them to go to hospital and get screened and get tested. And even if it's cancer, then they have someone to talk to. They'll talk to someone and ask, how did you do it? How did you cope? And that could help.
Doctor, in this country, we've gotten to a point where people are, let me just put it bluntly, sort of losing faith with our health professionals. I take my car to the garage. My mechanic tells me, let's change the shocks. We change the shocks. I go to hospital. I am diagnosed with something and somebody will tell me, get a second opinion. And the second opinion will in many cases, vary from the first opinion. So you start questioning, what is this? Evans is saying, what type of diagnosis is appropriate? He says he has a friend who periodically did tests but was diagnosed with cancer. Passed on this year. I wonder if the tests were any guarantee or what was happening with those tests.
Was it a test? Did he go for an examination or was
He was going for cancer screening.
cancer screening?
Okay. Now, for breast cancer specifically, I feel the gold standard of screening is a mammogram. A mammogram is an X-ray of the breast. And there's this one myth that people say that the mammogram or the X-ray can cause cancer or can make it spread, which is a misconception and a myth. The benefits of constantly screening with a mammogram outweighs the risks. And if you do a mammogram, it will show you if a lump is present. And after you visualize a lump, what we do, our oncologists do as well, is a tissue biopsy, where you take a biopsy gun, you take a bite of that tissue and you analyze it under a microscope. Now, if you do that, you will find out if the lump is benign, which means it's not carcinogenic and it cannot cause cancer or spread, and if it is malignant. From there, then you can analyze which treatment option based on the cancer tissue that has been found. And I feel that we need to empower our healthcare professionals as well, because one thing we need to know is, especially in our public healthcare facilities, they're not all the same. They're not all as well equipped as we might say Kenyatta is or Nakuru PGH is. And we need to have a workforce that can support each other. Because I believe if you are a doctor working a 24-hour shift or a 36-hour shift, you will not be as productive as two doctors who are alternating 12-hour shifts. And that's one thing we need to know. We need to improve on our human resource recruitment.
Of the numbers of lumps that are found, are the majority of them malignant as opposed to benign?
So it depends on the age bracket.
Okay.
Remember, in the West, breast cancer is seen above 40. In Africa and in Kenya particularly, our levels, we catch them very early. So it's the 30-year-olds, the 22-year-olds. Not all breast lumps are malignant. However, some breast lumps are malignant. So when we talk about it in general, not all breast lumps are malignant. Majority of them could be benign. But the only way to know, it's not the number of lobes, it's not how many they are, it's not how they feel. You can only tell if a lump is malignant by what Dr. Ari mentioned.
Right.
Taking it to the lab, having it examined under the microscope to see whether there are some cells that are malignant. So the lump might have areas that are not malignant, but if a certain part of it has malignancy, it needs to be addressed.
Okay. There was a campaign, I think it was 2 years ago, when, and I mean, the words that were used were, look, these are breasts, touch them. And the point was to be able to see if there was any kind of abnormality. And I guess we're still saying that today, whether it is you who is doing a self-test or whether it is, you know, a medical practitioner. But obviously, the regularity would be more with you as an individual. What are the chances of you finding something if you are regularly, you know, examining your own breasts?
Okay. I would like to mention that other than finding a lump, there are other changes that you need to look out for. You need to look out for. Because sometimes you might find these changes and not the lump. And this includes how your nipple anatomy is. If you have nipple inversion, your nipple is facing inwards as opposed to facing outwards. That is one very important sign you need to look out for. You also need to look out for...
As in suddenly it changes and starts pointing inwards?
Yeah. It changes, the anatomy changes. So you need to look out for your nipple. You also need to look out for any discharge from your nipple. So any blood, any discharge of abnormal sorts other than milk. Milk is life. Other than milk. And also you need to see the area or the skin surrounding your nipple and your areola. Is it reddish? Is it dimpling? Dimpling, I mean, you see how the orange looks. Those indentations of the orange. That's what I'm talking about. So you need to see it holistically. And see, the beauty of it is if you are regularly doing your breast exams, you will notice a difference. For example, asymmetry as well. Your breast symmetry, one is more asymmetrical than the other. If you do that regularly, you will notice a difference, isn't it?
Yeah.
That's what I'm talking about.
Okay.
And it kind of means that women have and men have to have this normal behavior of looking at their breasts. That means having a mirror in front of you and standing in front of you of the mirror and looking at the breast, because some of the changes, like he mentioned, will be very subtle at the beginning, and they need, and I know men don't have a good relationship with the mirror, but this is the time, unless you're wearing a tie, I think most men don't use the mirror.
The mirror isn't the problem.
What is the problem?
I'm just imagining myself standing in front of the mirror looking at my
Naked.
breasts. No, the naked bit isn't the problem.
Oh, okay.
It's me staring at my own breasts. That's the thing I'm trying to figure out. Here I'm looking, and I'm thinking, okay. All right, but anyway, please go on.
Yeah, so when we get over the fear of looking at our own breast, then you would stand in front of a mirror and you put your hands maybe on your waist, and that would help you see, because as you move the hands to put them on the waist, then you would see the muscles beneath the breast and how the breast would move. So if you notice one is moving and the other one looks fixed, then that's a sign that you need to look out for. Then you'd put your hands behind your head and pretty much observe and see whether your breasts are moving symmetrically. You're looking at the skin. Is there dimpling? Is there like a dimple now on your breast that wasn't there before? He mentioned the discharge. He's mentioned the skin. Or is there a lump? Is the size increased? So you see, if you know what's your normal every month, if there is a change, you'll be able to notice it. Then we recommend uniformity of when you feel your breasts. Remember, for women, it changes with your menstrual cycle. So if you can do it mid-cycle, I think when you say mid-cycle, it's a bit hard to process, but you say 10 days after your menses, that's pretty simple. You can put a reminder on your phone, because many women have an app that's monitoring their menses. So if you add that on to be the things you do, and then that would tell us you can catch it early. However, before you can see the changes, before you can feel the changes, then a mammogram would catch it even before, meaning earlier on. So it's important for us to go for breast cancer screening in the form of a mammogram if you're above 40. If you're below 40, then we're talking about an ultrasound and also a clinical breast exam. Remember, as doctors, we feel a lot of breasts, meaning a change that perhaps you might feel is just normal nodularity, we might be able to pick out.
Yeah.
It's like if I am a fisherman, there are chances of me catching fish are better than someone who does it for sport.
Right.
If it's my profession, then definitely
You'll know.
I know where the fish are. I become an expert. So that's the same with physicians who are actually doing breast examinations every day. The chances of them picking it out are better. And if you look at the guidelines, then self-breast exam has been put as an adjunct. It is not a diagnosis. Even clinical breast exam is part of an adjunct, but it is more likely to get a lump compared to when you do it yourself, because that's not what you do for a living. Yeah.
Can I ask this question? When you look at the statistics about relating to breast cancer, do you have statistics about the numbers of healthcare providers who are diagnosed and those who die from breast cancer?
Well, I haven't seen a particular study just focusing on health professionals, but we are in the population. So when you talk about 16%, then we are included in that number. When we talk about seven women dying every day, then we wouldn't seclude ourselves from the general population. So that will be a good study. But I'm wondering, what's your line of thought?
Exactly. When you brought in HIV, one of the things that was determined was part of the problem to people understanding HIV were not the reluctance of patients, but the reluctance of the care providers. They themselves had issues of stigma relating to HIV. So in conveying required messages and in actually doing what they were supposed to do, they themselves hadn't come to terms with the issues around HIV. So when it came to them providing the care that was required, because they themselves had issues, there was a limitation in the provision of care that they could have.
Well, it's very true. And I think sometimes the fear or the worry that a healthcare provider has would be different from someone who doesn't work in hospital. Remember, the patients who come to hospital with cancer are very sick. So when you go for screening, those are the images you have in your mind. So I guess that's part of the trauma of working in a health facility that you develop over time. But I guess the messaging we have even in the hospitals, or the messaging we have in the form of continuous medical education, is helping the healthcare providers actually take up the service. You'd find many facilities saying, we're going to have a breast cancer screening, but we're starting with our staff. We're going to find a health. Then they actually put it as, have you come for the screening? And there's going to be maybe a ribbon that you get if you've gone, and maybe none if you haven't gone, and sort of to help you see the need to go for screening. So what I would say, this messaging applies to all of us. We are all in the population, healthcare workers, non-healthcare workers. We need to take it seriously. We need to see that the lives that are being lost currently are too many. Are too many, and we can do something about it. We can get screened even before we see the changes, and that means we'll catch the cancer early.
How much is a mammogram today around the country? I know that there are some free ones, but how much is one? Because obviously looking at that as a factor, a determinant of how often people are going to go and get screened.
I feel it varies between public and private facilities. At Kenyatta, last I remember, it was 1,000 shillings, Daktari. Currently, for my facility, we're giving offers for the whole of Breast Cancer Awareness Month, Equity Afya, so we're getting 50% off for mammograms for all cancer-related tests. So I think it varies.
So 50% off equates to?
For example, let's say the mammogram was 2,500, we're doing it for 1,500. Yeah. So if it's a PSA, we were doing for 2,500, we're doing 1,500. So I would invite everyone before October ends to come to our facility at Equity Afya Kangemi, and we can give them those subsidized offers. But they vary from private to public facilities.
So looking at those as determinants of whether an individual is going to come in and get tested or get screened, then seems to me a precluding factor.
Well, it has been.
It has been.
It has been because
now, if we're looking at 1,000 shillings, the truth of the matter is that the majority of the population, when you look then at 1,000 shillings vis-a-vis the other things that you're going to do for something that's not painful, then
it can wait. It can wait.
Absolutely, it's a no-brainer
Yeah.
in terms of what you're going to select. So then, I guess the question then, when we look at preventative care, is that we have to look at the costs of it as well, and it's got to be an everybody conversation. That how then will we make sure that preventative care is what we are going to, because obviously curative is much more expensive.
Very true. And I think that's where we're going as a country, and that has been a question that has been raised on several occasions, not just in this forum. How do we ensure that healthcare is accessible to the local mwananchi, the mama mboga, who's not able to get the 1,000, the 2,000 or the 3,000 for a mammogram? And that's where the country is going in terms of health. Previously, NHIF would not pay for anything that was diagnostic. So it wouldn't pay for screening. It wouldn't pay for the mammogram in most facilities. So now we're getting to a place now the conversation is shifting from just treatment to prevention. And here's where we're having the universal health coverage. And what it's looking into is how do we focus on prevention? Because definitely, if we caught the cancers early, the amount of money we are spending on treatment for metastatic disease, on treatment for advanced disease, would be focused to a larger population. We would be able to save a lot of money and save lives at the same time by catching cancers early. So universal health coverage is looking at ensuring we are focusing on prevention, ensuring messaging like this is done, ensuring diagnostic is covered in the treatment, because you'd find someone has a lump or even a big ulcer, but they can't afford the biopsy, they can't afford the imaging, the CT scans that they're supposed to have. And then sadly, as Kenyans, we have one, very poor health-seeking behavior. So we go to hospital, like I said, only when things are very bad. Two, we have very poor compliance to insurance. So we take insurance when we are unwell. So most patients, even who are diagnosed with cancer, when they get the diagnosis of cancer, that is when they take insurance. So that reduces the capital base that the insurance has in order to cater for most of these services. So now when we're looking at universal health coverage, it means everybody's contributing to the pool, ensuring there are funds to diagnose, to prevent, and now to treat. And that would really help, because like patients who had breast cancer, the chemotherapy, NHIF would pay 6 cycles, like for the first line. Then for the second line, they could maybe pay another 6, but in every financial year. But there's some chemotherapy regimes that are 8 cycles. that would mean the patient had to foot the bill. So if per cycle it's 25,000, it meant the patient needed to have 50,000 to complete the treatment.
Yeah.
Sometimes other drugs are even more expensive, maybe 60,000 every 3 weeks. You see, even for me, if I was to pay 60,000 or
It's a lot of
100,000
money.
every 3 weeks, I would feel the dent.
Yeah.
I would perhaps not even be able to afford that. And that's why you'd find even doctors, when we get cancer, or healthcare professionals, you'll still see an M-Pesa changa. We're going to come to you to ask for money because the treatment was very expensive. So we're looking forward to seeing how this UHC will be panned out, because it really looks like it's going to change healthcare. It's going to change how we look at things and how much, and increase the access to care, both at preventive, diagnostic, and treatment levels.
We'll be having a UHC conversation in the next hour, and we'll have them continuously to just seek to understand what is being rolled out in UHC. But as a final conversation, you're saying people should make it a habit to check themselves. And then people should make it a habit to regularly go for screening. How regularly? Once a year, twice a year?
We talk about once a year.
Okay.
I always try and say in October, everybody's going to talk about it. There are companies that will give it for free.
So do it then.
Do it then, because something's going to remind you about breast cancer screening. The when to start. Remember, if I have a strong family history of breast cancer, like my mother had breast cancer, my aunt had breast cancer, or
Yeah.
my sister, then I would start 10 years before when they got the cancer. And the screening is important. Early detection actually saves lives, and we really need to focus on it.
Good message. Dr. Dulcie Wanda from KNH and Dr. Hussein Dimbil from Equity Afya have been our guests this morning. Keep it here. UHC conversation coming up in the next hour. It's 8 a.m.
This is the Situation Room, the only way to start your day.